I am Professor Paul Sidhu from King's College Hospital in London. I'm very pleased here today to talk to you on an update on the EFSM guidelines for the use of contrast-enhanced ultrasound. EFSM is a well-recognized organization. The European Federation of Societies in Ultrasound in Medicine and Biology was established in 1972 by 13 European countries. It has grown over the years to 32 membership societies and has over 21,000 members. It has several important committees, and the most important committee, of course, is the Publication Committee, where a lot of these guidelines will emanate from. I'm talking to you today on contrast-enhanced ultrasound, and it's important to remember that contrast-enhanced ultrasound has been with us now for over 25 years. I started off in 1995 with the product Levovis, looking at the Doppler rescue use of it in the portal vein and the hepatic artery, but it's grown into an enormous amount of uses across the world, and there's an enormous amount of literature. There's over 4,000 papers now in the literature. EFSM has always been at the forefront of developing guidelines, and the first set of guidelines on the use of contrast-enhanced ultrasound agents was in January of 2004, and subsequent a further update was produced in 2008. In 2012, EFSM got together with its colleagues across the world in cooperation to produce the contrast-enhanced guidelines in liver use of contrast. And subsequently, further guidelines have come up, and the 2017 non-hepatic use of contrast-enhanced ultrasound was developed. And more recently, the liver contrast-enhanced ultrasound guidelines have been updated in 2020, again in cooperation with a number of societies across the world. And very shortly, we will be producing, in the next 2 weeks, a brand new position statement, in fact, a proposal for contrast-enhanced ultrasound-adapted Bosniak cyst categorization, which we think will be a very important benchmark paper for how this is practiced across the world. It's important to realize that we use contrast-enhanced ultrasound because it's safe, and the recommendations in the guidelines have always indicated that intravenous contrast-enhanced ultrasound is safe and effective in adults and children. Intracavity use of contrast agents is safe, and the society would not be advocating the use of contrast-enhanced ultrasound so widely if it wasn't proven to be the case. If you look at the post-surveillance assessment of the safety of contrast-enhanced ultrasound, and this is using just SonoView, anaphylactoid reactions occur in 0.014% of patients, and severe anaphylactoid reactions are said to occur in 1 in 10,000 patients, and the fatality recorded is 14 in over 2 million doses. Contrast this with CT iodinated contrast, where the fatality is much higher. Most of these fatalities occurred in the cardiac group, where these patients were undergoing stress echocardiograms. Important also to remember, when we are looking at guidelines, and EFSM has produced guidelines, you also have to understand that it's not always the liver or other licensed areas where we're producing guidelines, and this is reflected in the contrast-enhanced guidelines in non-hepatic applications. And when you produce a set of guidelines, as we did in 2011, on non-hepatic applications, we also at the same time produced an editorial to go along with this. Because if a scientific society is advocating the use of a product which is not licensed, and in this case it's primarily been SonoView in Europe, where it is only licensed for the breast, peripheral vascular system, the heart and the liver, you have to justify why a scientific society is saying it is safe to use these contrast agents. And this editorial at the time of the production of the 2011 guidelines outlined why contrast-enhanced ultrasound should be used. Primarily, it has lots of advantages over CT and MR. You can perform it immediately without any preliminary laboratory testing, and it can be carried out in a variety of scenarios, the bedside, the operating room, the CT suite, and you see those changes in real time. So it's a very useful tool for any clinician or sonographer when they're interpreting an abnormality in a patient. But these are off-label uses, and very many uses that the guidelines are advocating that you should be doing will never actually become licensed. But in the United Kingdom and in a lot of countries in Europe, this is not an issue with the regulatory authorities. Because if you, and this is pertaining to the General Medical Council of the United Kingdom, if you as a physician administer a contrast agent, you must be satisfied that it would better serve the patient's need. You be satisfied there is sufficient evidence base or experience using that medicine to demonstrate its safety, and then you take responsibility for prescribing the medicine. And this is where the guidelines give you all this evidence and allow you to use it off license. The European Federation of Societies in Alzheimer's Medicine and Biology also have a policy document for a development document strategy for producing clinical guidelines, position statements, and technological reviews. And any new guidelines or position statements that are new and are going to be developed have to follow these guidelines. And this is a very strict criteria. First of all, of course, there is suggestion of topics, and these suggestions come from a wide variety of sources, predominantly by members of the EFSM Executive Bureau, but also members of the other committees of EFSMs, and also from editorial board members of the journal and other member societies. These proposals are first subject to review by the Executive Bureau, and a final decision is reached by consensus by the Executive Bureau. A description of the overall objectives and clinical and technical questions are covered, and then a short explanatory statement is produced to say why we're going forward with this development. And when all of this is done, you've got to be looking at why you should be producing position statements, etc. It has to be relevant to the healthcare system, clinical medicine and imaging, in ultrasound in particular. There's a potential and necessity to be able to change current practice, improve quality, and reduce variability in performance. And also there's the urgency of the topic, and this is the one reason why the position statement in Bosniak CIS was produced just recently. And it's also useful for cooperation between national and international societies and institutions. And you also have to be absolutely sure that there are resources and financial support to develop these guidelines, because these guidelines have some cost to the development. Clinical practice guidelines are the most important guidelines, and these are the ones that are very strict on evidence and will then give you an actual statement which tells you how you should be using it. And this development process is according to the appraisal of guidelines for research and evaluation, the agreed to criteria. So it's very important that it's very strongly evidence-based. So let's just go back now to the reason why we started this set of guidelines, and this is to explain to you how we developed and produced these guidelines over time. So even though the non-hepatic guidelines were finally published in 2017, the Executive Bureau made the decision to do these guidelines in 2015. So it took over 2 years to actually bring these guidelines into publication. A steering committee was formed, and these are the main people on that steering committee. A chairman was appointed. All expert members were contacted. We had to develop a system where we would identify expert panelists, and this is mainly through publications and the experience of people within Europe. Rules are set out, the criteria for evidence and inclusion are set out, and then you develop a time scale of the manuscript, aiming to have an expert meeting, and on this occasion it was in London, and this was in June of 2016. So this is the timeline, and it's very strict. The dates were actually fixed 2 years in advance as to when things would happen. So in February of 2016, everyone was contacted. By July of that year, the meeting had occurred. The draft had been revised by September of 2016, and further revisions were corrected throughout 2016, and the manuscript was submitted and accepted in July of 2017. So it has to be a very determined effort by a large number of people to get these guidelines into publication and print. The expert panel was quite large, Some of these doctors on the expert panel did not need to come to the physical meeting in London of 2016, but most of them attended to give an opinion. And I must say the expert meeting is a long day. It was about 12 hours and very exhausting for everyone concerned, because you are debating and arguing and voting over whether or not the guideline wording and whether the application is suitable. So by the end of the day, you have achieved something quite substantial when everyone has agreed on the guidelines and the recommendations. Just very quickly to show you, these are the chapters of all the guidelines that were developed, and there was a large number of areas which were considered for entry into the guidelines, and each of these areas had particular experts who were developing the guidelines, looking at the literature, assembling the references and putting together their section or their chapter. Most of the doctors in these groups will produce a section that is probably too long, and this takes considerable shortening to make the guidelines useful. The guidelines are based on levels of evidence according to the Oxford criteria. And it's important to enter into the guidelines, and you'll see this in the guidelines, what level of evidence is the recommendation has. So a recommendation, a level of evidence of 1A against the recommendation is the highest possible. And these are the double-blind crossover trials, very few of which occur in radiology. And if there's a level of evidence of 5, it's only expert opinion without critical appraisal and is based on experience. So the reader of the guidelines has some idea when a recommendation is made of what sort of level of evidence there was to produce this. If there's no evidence, it doesn't mean that a recommendation will not be made, but it's important to say this is only expert opinion. And then you grade the level of recommendation based on this. Grade A is a very high grade of recommendation, whereas grade D is based on the inconsistent or inconclusive studies of any level. And then each recommendation is voted by each of the panel members, so that again the reader of the guideline gets an idea of how much agreement there was with the panel members on that particular recommendation. So just summarizing that for a moment, you've got a process where expert doctors and reviewers have looked at the literature, put together a paragraph or a chapter, have detailed the level of evidence and graded the recommendation, and then that recommendation is voted on. And this is our expert panel, and this was in 2016 in London. And after 12 hours of arguing and deciding what is right and what wrong, we're still able to smile. And these were the countries from which most of the members were from: Italy, the United Kingdom, Germany, and several other countries within Europe. So what did the guidelines look like? Well, so when eventually they were published, the non-hepatic applications update in 2017, and you'll see there's a short version and a long version. The short version goes into the print form in the publication without references. The long version is published online with all the references. These guidelines made in total 74 recommendations. And here you can see at the bottom of this recommendation, the level of evidence is 1B, the grade of recommendation is A, and the broad consensus, 15 out of 19 of the participants voted for that recommendation. And recommendation 1, you can see, was very strongly supported by the panel, where 20 voted for it. So what are there in these recommendations that show that the very good levels of evidence in the non-hepatic use of contrast-enhanced ultrasound? Genitourinary, well, the kidney. The kidney had 6 recommendations and very strongly recommended that you use it. And in fact, this is one of the areas that a lot of people who are doing contrast-enhanced ultrasound will tell you that this provides the best clinical assessment of complex cysts in the kidney for complex tumors as well. Contrast can be used to diagnose ischemic renal disorders very easy. Contrast can differentiate between renal tumors and anatomical variants very easily. Contrast can be used to characterize those complex Wozniak cysts. Contrast can characterize indeterminate renal lesions. Contrast can be used for identification of renal abscesses, and contrast can be used for the follow-up of non-surgical renal lesions. You will notice here that the contrast does not give you a histological diagnosis. You cannot identify a renal cell cancer, and you can't differentiate it from a papillary cell cancer. This is still research, but there's no place yet as a recommendation. In the scrotum, there are areas where it's really quite useful, but it's useful in areas where it's ischemic or non-vascularized. So contrast can distinguish vascularized from non-vascularized focal testicular lesions, helping to exclude malignancy. Testicular contrast can discriminate non-viable regions in the testicular trauma. Contrast can identify segmental infarction and abscess formation. You will notice there's no recommendation for identification of different tumors in the testes. This remains research work and cannot be put into guidelines just yet. It's also very useful in the bladder. The most useful application in the bladder is the differential diagnosis of bladder cancer from hematoma in those patients with hematuria. This is very strongly supported by the panel. The pancreas, it's useful in solid pancreatic lesions to characterize ductal adenocarcinoma. It can be distinguished between pancreatic ductal adenocarcinoma and neuroendocrine tumors. In the GI tract, it can evaluate the vascularity of the GI wall and tumors. It can be used to estimate disease activity in inflammatory bowel disease. And this is a very important application that will develop over the next few years, because remember, in all the time you're using contrast-enhanced ultrasound, you're not subjecting the patient to other imaging modalities which may have increased morbidity. In the spleen, it improves the detection of focal abnormalities, but it doesn't differentiate for you benign and malignant lesions. In abdominal trauma, it's excellent to see trauma injuries in the hemodynamically stable patients as an alternative to CT. It's useful in gallbladder disease, in acute cholecystitis, to detect local complications. It actually gives you a much better idea of what's going on. In the carotid artery, it can differentiate total carotid and vertebral occlusion from residual stenosis. A well-known application is in the endovascular aortic repair and endovascular leakage from that repair. And in the cerebral vessels, it improves your transcranial Doppler assessment of those vessels. We also looked at novel and unusual applications to make recommendations, because more and more people are using the contrast in these areas. For instance, there is a recommendation that it can be used in inflammatory joint disease to look at the active vascularization for treatment monitoring. There is evidence out there that it's useful. And this is most important too for neurosurgeons. Intraoperative contrast-enhanced ultrasound in neuro-oncological procedures for tumor identification and assessment of the boundaries is very important. This is an area where the neurosurgeons are more likely to want to use intraoperative MRI at great expense to look at the residual tumor. But with a simple ultrasound and contrast-enhanced examination, you actually get a lot more information from this technique. And this will develop in the future. Interventional contrast-enhanced ultrasound, avoiding necrotic tissue, identifying perfused tissue to help do tumor biopsy. In interstitial ablation therapy, this too has found a niche, and intracavity uses where you're looking for identification of the needle at catheter position or delineation of a cavity. And of course, there's tumor response assessment. And this is an excellent bit of work where you can assess whether or not the vascularization of that tumor reduces before the size of the tumor reduces. And so you know your anti-angiogenesis chemotherapy is working. So these are your recommendations are quite strong. But there are areas which have less good levels of recommendation because they have less good levels of evidence at the moment. But this will develop in the future. The adrenal glands, you cannot differentiate malignant from benign adrenal tumors, but you can tell the difference between a vascularized tumor and a hematoma in trauma. In obstetrics and gynecology, there is no recommended clinical evidence for gynecological adnexial masses yet, but this will change. And prostate cancer has been showing a lot of promise, and it's developing. And the same with thyroid. And I know there's been a lot of research work in the world on thyroid disease, but it hasn't reached sufficient levels of evidence to make a recommendation that you can use it in thyroid. And the same with lymph nodes and salivary glands. The breast first developed and licensed for breast contrast-enhanced ultrasound, but there is no consensus or evidence yet that it should be used for breast evaluation. Sentinel lymph node, there is evidence out there that an intradermal injection of contrast agent will identify a sentinel node, and this is active research, and this will change over time. So at the end of the day, there were 19 chapters, 17,500 words, 74 recommendations, and 578 references in this document. A huge bit of work, and all these people contributed to this project and developed these guidelines. And these guidelines have already now established in a couple of years with over 300 citations in the literature in a short space of time. So it indicates to you that that hard work has actually paid off, and the document is used across the world as a standard reference to the practice of contrast-enhanced ultrasound in non-hepatic applications. But one thing that was missing from this was pediatric contrast-enhanced ultrasound. Now, pediatric contrast-enhanced ultrasound, we know, is not licensed anywhere in the world, but only in one country at the moment. But it's very useful. And much to our surprise, we learned in 2015 that the FDA was looking at the application of contrast-enhanced ultrasound in pediatric patients. And on April the 1st, 2016, the FDA in the United States approved SonoView, or Lumason as it's called in the United States, for the first time for radiological use in the ultrasound of the liver lesions for characterization of focal liver lesions in adult and pediatric patients. All of a sudden, we now have a tool to assess pediatric patients with contrast-enhanced ultrasound. And this is important because the pediatric patients are the patients that will most benefit from an ultrasound examination. It'll be most likely the most diagnostic. So it's now FDA approved, and this is 4 years on now. So what we did, we anticipated that this was going to happen, and that EFSM produced a position statement. And the position statement was to deal with the mounting evidence of usefulness of contrast-enhanced ultrasound in children in many areas, and to look at the further development of this technique. And position statements are different from guidelines. Position statements are summarizing the EFSM opinions on important current issues in clinical application, education, and training of ultrasound techniques. It's not offering guidelines. And this is very important to make this differentiation, because there's not enough robust scientific evidence to produce guidelines on that particular topic. And this is the group we put together to put the position paper through. Less arduous. We didn't all meet up physically. We corresponded by email to draft the position paper. And in this position paper, we looked at a number of areas for which contrast was being used in Europe in pediatric patients. And basically, the main areas that we found there was already some evidence was that it was safe. The data in Europe was showing that there were very few reactions in children. Most of the people in Europe were using it to characterize focal liver lesions, but more importantly, it was used quite substantially across the European countries, looking at solid organ injuries in abdominal trauma. And there were many position comments, and remember, it's a position comment, not a statement or a recommendation. And one of the other areas was that it was developed, and fairly well developed, is transcatheter injection in voiding urosonography, looking at visoureteric reflux. And this is a paper we produced from our center when we had performed the first 305 pediatric patients, just documenting how these numbers increased over the years in our practice, and how it was completely safe in our hands. But however, when we published this position paper, we were criticized, and the criticism was from a group of pediatric radiologists who believed that the review of the literature was optimistic and inhomogeneous. In particular, it is evident that the conclusions come mainly from radiological experience acquired on the basis of adults. This is not completely true, because our position authors were nearly all pediatric radiologists, and all of them had contrast-enhanced ultrasound experience. But it's important to note that if you don't make changes earlier on, and you overcome reactionary attitudes to the more widespread use in children, you'll never develop this technique. So hopefully our position paper will be used as a basis to which to develop contrast-enhanced ultrasound in children. And we owe it to our children to use as much ultrasound as possible. Contrast agents in ultrasound are safe. Using a CT examination and radiation exposure, you have a subsequent risk of leukemia and brain tumors. We just don't know what the gadolinium retention in the body and the brain is over long term, and there are also implications for giving anesthesia with the developing brain. So when you use ultrasound, you don't need any anesthesia or sedation in the patient. The patient doesn't need to keep still. The parent can be in the room, and you will get your ultrasound examination done. And I draw your attention to this publication from my group at King's College Hospital. And this is a nice book if you want to look at pediatric imaging and contrast-enhanced ultrasound. And also encourage you to, if you can, to submit your cases on pediatric contrast-enhanced ultrasound to the EFSM registry, which is available online. It was previously restricted to European examiners and observers, but is now open across the world. SonarView data so far, we have 1,600 patients on the database, and there is a publication on the early data from this registry due to be published very shortly. But more importantly, an important development with EFSM, and this come through in the last year, you can become an EFSM member, even if you don't live and reside in Europe, as an individual member. And if you look at the website and click on this button, you'll find that it's very useful aspect, and it doesn't cost you too much, and you'll have access to all the educational material that EFSM produces. But more importantly, you can and will be invited to join committees and develop guidelines when you're an EFSM member. So I thank you all very much for listening to me, and I invite you to London in better times to come and stand on the helicopter pad at King's College Hospital and enjoy the view of London. Thank you very much.